total cases and 5th in the neuroinvasive cases. That's not quite linear to me. I don't understand how we can be lower in the cases and higher in the actual neuroinvasive cases. There were also, what I found interesting, 3 viral blood donors in Mississippi in 2017 that actually donated blood that was infected with the West Nile virus. You guys all know the signs and symptoms, obviously, but the one that we're going to focus on today is headache. Some otherwise healthy people may continue to experience these headaches or difficulty in concentration, and I can hear myself over there. This can last for several months, and in some patients that I've seen, it can actually last for several years. What do you do when the virus attacks the brain? That's considered to be neuroinvasive. You all know what neuroinvasive means, I'm sure. The West Nile neuroinvasive disease processes are considered to be the aseptic meningitis, encephalitis, and anterior myelitis. We'll be focusing on 2 of those. As you see, I've put in bold all of the side effects and the long-term, short-term outcomes that involve headache. West Nile meningitis type, whenever you get the meningitis, you of course experience a headache, but then you experience an exacerbating head pain over a short time period, and that can convert you into a chronic headache state. Increased intracranial hypertension as associated with encephalitis can be long-standing and very hard to treat. Cerebral edema obviously can cause a headache, but that is infrequent. The anterior myelitis is not necessarily associated with the headaches, but it is weakness and paralysis similar to the polio disease. So how does the virus get into your brain? The exact way that West Nile is able to invade the nervous system is not really known, but the researchers that have done research on animals think that a substance called the tumor necrosis factor in the brainstem can make the brain more permeable to the virus, and when the virus enters the brain, it doesn't just sit there, it affects the most important nerve cells found in the basal ganglia, the thalamus, and the pons. Increased tumor necrosis factor was found in the spinal fluid, but not the blood of patients with chronic migraine, new daily persistent headache, and people that had had a viral infection. So what are the pons, the thalamus, and the basal ganglia? The pons, it really controls things like your bladder, as you can tell, as a little guy who has to go to the bathroom, your posture, your facial expressions. The thalamus can control your motor coordination and movement, and the basal ganglia can control your consciousness and alertness. And if you think about the symptoms and the side effects of the West Nile virus, you'll realize that the things that these 3 areas control are the things that are most affected and are displayed symptomatically. So, is headache an indicator of the West Nile virus, a short-term result, or a long-term outcome? It's really unpredictable. Headache can be one of those, it can be all 3 of those, and you don't really know which one you may be. The headache subtypes that are associated with this virus are the acute headache that's associated with the onset, the headache that you may have felt that may have led you to understand that you needed to go to the doctor and get some treatment. The headache attributed to viral meningitis or encephalitis, that is a short-term headache, typically resolves about a week after the virus is completely, that you're asymptomatic. Chronic headache attributed to systemic viral infection is often classified in the headache world as what they call new daily persistent headache. Most of these patients can pinpoint the exact day that their headache started, and most of the time it is post-viral or post-infection. All of the secondary headaches related to the West Nile virus can present clinically similar to either episodic or chronic migraine and new daily persistent headache. So the things that you experience when you have post-viral headache are really closely related to the things that people that have disorders such as chronic migraine experience. And that the headache is typically treated as the primary headache disorder that it most closely resembles. So it kind of wants to be like migraine. You guys can read these on your own. These are just the diagnostic criteria for the headaches that I'm going to be talking about. The headache attributed to the viral meningitis or the encephalitis. The chronic headache attributed to the systemic viral infection. This is when the headache has been present for greater than 3 months, which is very common. new daily persistent headache. In the neurology world, we'll sometimes say, or the headache spectrum, that the diagnosis of new daily persistent headache is a way to get out of doing tests on the patient and trying to figure out exactly what's wrong. Several people don't believe that this is a real diagnosis. And I would have to agree with that, because a lot of research has shown that 30% of new daily persistent headaches that were diagnosed that way, their first headache day correlated with that viral or infectious process. It has features suggestive of chronic migraine, so it's frequently misdiagnosed. These patients don't indeed have migraine. When the criteria are fulfilled and the patients have had a headache that is daily and unremitting from 24 hours after its first onset, it can be considered new daily persistent headache. These people don't have a day that's pain-free typically. They have hours sometimes, but never a day that they're pain-free.
I'm sorry, how many days do you have to have it in a row to become daily?
3 months.
Oh, 3 months.
Mm-hmm. Migraine without aura, this is the correct diagnostic criteria. I will point some of these out. Headaches that last 42 to 72 hours untreated or unsuccessfully treated. 2 of the following characteristics: they're unilateral, pulsating, they're severe. You can't do jumping jacks when you have a bad migraine. You don't want to move around. And during the headache, you have either you get nauseated, dizzy, you vomit, or you're sensitive to light and sound. Most people with migraine are also sensitive to smell, but it's not listed on the diagnostic criteria. Chronic migraine is a headache that occurs 15 or more days a month for more than 3 months. On at least 8 days of the month, it has the features of a migraine headache. This headache has to be present for 3 months. On greater than 8 days out of 3 months, the headache fulfills the migraine criteria, and that's how it's diagnosed as chronic. And chronic viral, post-viral headache follows under the same criteria. So do we even know the pathogenesis of the most common headache disorder known to man? No, we do not. There are several theories. That's a long no. I'm not going to read this to you, but migraine was long thought to be a vascular and a vasoconstrictive disorder when in fact it's not. It does have some components of vascular disorders, meaning that it affects the blood vessels in the head. Used to, people would say that their head was swelling when they had a migraine, and we know now that that's not the case. It's known to be a neurovascular disorder, and it involves the brainstem responses and the increase of certain chemicals that are in the brain that are not increased in the people that don't have a headache. It involves cortical spreading depression. That's just like I describe it to my patients as little lightning bolts traveling along your head, and that can cause you to have sensory disturbances like visual problems, speaking problems, and in some cases even problems with moving around or mobility. The most important thing right now in the scientific world with headache is the vasodilator, the calcitonin gene-related peptide, and we call that CGRP for short. It is increased in people that have headache disorders, not only migraine.
I want the Chick-fil-A meal with a Dr. Pepper.
Also, serotonin is one of the most important receptors. I know that everybody knows what serotonin is. And the 5-HT receptors are the ones that the triptans work on. And triptans are medicines that help headache. The fainting goat theory, I made the name up, but it really is a theory. The theory that they have is that headache originated as a human's natural response to an unwanted or negative stimuli. So it's kind of like the goat. Your body just wants to shut down. So one half of your body, when you have the bad headache, wants to shut down. The other half of your body says, no way, I'm not going to let you shut down. So it releases all of these brain chemicals, and that release of chemicals and that process is what causes you to have the head pain. So I like my little goat right there. I think he's pretty cute.
Did the goat have a headache? Or?
Surely he did, after falling like that. Post-traumatic. Today's focus is really on the long-term headache outcomes. I know that's what most of you, if you have headaches related to your past history of the viral infection, are wanting to know. Well, what are you going to tell me that matters to me? Both chronic headache attributed to the systemic viral infection, new daily persistent headache, and chronic migraine often have the same pathogenesis. In other words, the same thing is happening in the brain, so they respond to the same treatment. The pathogenesis of chronic headache attributed to systemic viral infection, the patho is difficult to speculate on this, of how it works exactly, because we don't even know how migraine works. Researchers do know that it involves the meninges of the brain, and it involves the exact same chemicals as migraine does. These are just some research studies that I found. The research is very, very, very limited on post-viral headache. Everybody wants to focus on post-traumatic headache or post-concussive headache, and when in reality, they're all pretty much the same. You have an unwanted stimuli, your body freaks out, your brain chemistry kind of changes, and then you have a headache. So in 1987 was the first time that someone thought about that, and he suggested that the post-viral headache was related to new daily persistent headache or other chronic headache disorders. He looked back on people's charts that had infections, and he found that people that were diagnosed with new daily persistent headache that we were talking about earlier made up anywhere between 30 and 80% of that population. That's a large population. So in each individual chart review from each individual facility, it was between 30 and 80 patients that were diagnosed with new daily persistent headache that had a viral infection prior to the onset. There was another study that performed a comparison on new daily persistent headache in post-infectious, non-post-infectious patients. I'll let you read that, but the main thing is that the migraine pathology and meningeal signs were more prevalent in those with a history of infection. So the migraine group, the headache group, that claimed they had the headaches actually had less signs of migraine, like sensitivity to light, sensitivity to sound, than the people that were post-infectious. The post-infectious group had more continuous headaches, so they had less pain-free days, longer durations, and a lower proportion showed complete response to treatment after 3 months. So fewer responded, so that leads you to know that it is harder to treat than migraine, but it can be done. So I already had headaches, but West Nile virus made it worse. Why is that? Contracting a virus can increase the severity of the headaches in pre-existing headache or migraine, so aggressive treatment in the early stages of the headache is what's going to prevent that patient from becoming chronic. And then some people that have never even had a headache before get a post-viral headache. So if you think back to that little goat, the threshold to the nervous system is lowered during that viral process. You also have some risk factors if you have a family history of headache, if you're a lady, if you had chronic pain like fibromyalgia or any of the occipital neuralgias, anything like that can make it more likely that you may get a post-viral headache. Also depression, and I'm not sure about low socioeconomic status. I really don't think that matters, but that's what the research said. So now what do you do when your headache is chronic? Well, you need to demand answers. You need to seek treatment from a headache specialist or a neurologist immediately. Remember that although it may be more difficult to treat, most chronic post-viral headaches respond to the traditional therapies. So we're going to talk about those. What do you do when you have the headache? We use prevention and attack plans to A, lay the foundation for preventing the headache, and B, attacking the headache when it breaks through or becomes worse. And these are just some of the medications that we use for both migraine and new daily persistent headache and post-viral and post-concussive headache. So the National Headache Foundation did a small study, and they stated that antidepressants out of this category have the highest level of evidence for post-viral headache. Anti-seizure drugs have the most evidence for migraine. Botox, onabotulinum toxin A. It is currently the only FDA-approved treatment for chronic migraine. And you may say, well, I don't have chronic migraine, I have post-viral. Well, when you do your exam, you have all of the features of migraine. So you can get the Botox, and it does work. prescription medicine that's injected in your head and neck in patients that have that chronic migraine greater than 15 days a month. It can prevent at least 8 to 9 of your headaches, but typically in someone, you know, without a lot more comorbidities, they're generally a healthier person. I've seen it work to prevent headache completely. It reaches its complete efficacy by the 3rd time you get it injected. It works by paralyzing the musculature in the head. So you inject Botox, which is a toxin, and it's a paralytic. You inject it into your head, and it paralyzes that muscle. It doesn't work that way. It paralyzes it, but in doing that, it also prevents those neurotransmitters and those neuropeptides that typically respond along a pathway. It blocks the receptor. So your pain physically cannot be transmitted via that pathway. It is safe for those that have contraindications to other treatments. If you've had a heart attack or a stroke, a bleeding disorder, you know, stomach ulcers, cataracts, glaucoma, kidney stones, asthma, diabetes, you're not able to take a lot of the drugs that we prescribe. So Botox is a really safe alternative for those people. I tell my patients that Botox is not absorbed systemically. It doesn't go through your bloodstream. It doesn't sit in your stomach. Doesn't go through your kidneys. It stays where I put it, and the way that it works where I put it is what causes it to be effective. And if you want more information on that, there's the website for Allergan, which is the Botox for chronic migraine company. The injection sites for you to look at. Looks like a lot, but it's not. It's really fast. Takes about 10 minutes. 31 injections. Nerve blocks.
I'm sorry, 31 injections?
31 injections. The procerus, the corrugators, frontalis, temporalis, occipitalis, cervical paraspinous, and trapezius on both sides.
Is that like the accepted protocol?
That's the paradigm. Mm-hmm.
Wow.
Yep. And it works. I get it myself. I have chronic migraines, and it's effective for me.
Okay, thank you.
Mm-hmm. Nerve blocks are injections of numbing medicine. We use anything from bupivacaine, marcaine, lidocaine over the major nerve pathways in the head. In the back of your head, you have 2 really big nerves that can become irritated and inflamed, and it can make you have impulses all over your head to have a complete headache, a whole generalized headache. It's used both as acute and preventive therapy. In some patients, it can, and I have seen this work. These procedures work really well for post-traumatic, post-viral, post-concussive, post-infectious headache. They work really well, but in some people, they don't work preventively and they get a little bit of relief from their headache, but the goal is to get the nerve block to last for about 4 to 6 weeks with no headache. It's really scientific, but the best way to explain the way that the nerve blocks work is imagine that you have your phone and it's stuck in the little thing that goes round and round and spins. You know what I'm talking about? So when your phone gets stuck, what do? You turn it off, right? You do a hard reset. You turn it off, and then you turn it back on. And it's working, and you really have no idea why. I mean, you're just like, okay, well, I'm glad it's working now. That's pretty much the concept behind the pathophysiology of how a nerve block works in the brain. It's the most popular procedure at our facility. Everybody loves them. This one is 29 injections. It's not pleasant, but the after effects, if you've had a headache for a really long time and you get a nerve block and you're pain-free for the first time in months, then it's worth it. It can be used with steroids to abort a headache process that's lingering. So you can actually mix steroids in with your numbing medicine and give it a better chance of shutting a headache process down that's been active for a long time. The SPG block, sphenopalatine ganglion block, the sphenopalatine ganglion is a big old bundle branch of nerves that's back here behind your nose. When a lot of people think that they have sinus headaches, that's the nerve pathway that's being affected. It's used for both acute and preventive therapy, just like the nerve block. Got a chance. It may not work preventively, but it will work acutely. We take a catheter that's about the size of an angel hair pasta noodle, and we instill that lidocaine, liquid lidocaine, over one of those nerve branches that's responsible for headache. You can get these like every week. There's no real limit because it's just lidocaine. So you can inject them, you can instill them weekly if that's what you need to have done. They're instantly effective, minimally invasive. The way that the procedure feels is like you're underwater and you breathe in chlorine. It burns just a little bit, but it's not highly unpleasant. That's what it looks like. It looks a lot worse than it is. Some non-pharmacological interventions for migraine or for post-viral headache are the same ones that are for migraine. You have cognitive behavioral therapy, biofeedback, diet, exercising, physical therapy with myofascial release can help some people, sleep regulation, and understanding what medication overuse headache is. A lot of times when people have a daily headache, they daily medicate. They take Excedrin, they take BC, they take Advil, they take ibuprofen. They think that, you begin to think that you can alternate the different forms of it and it's not going to make you go into rebound headache, but that's not true. All of those medications, some more than others, have the ability to make you go into a rebound headache or a medication overuse headache if you use them even more than 10 times a month. So when people use them every day, they're putting themselves at risk for developing a different type of headache. And then you don't know what your baseline is. Acupuncture has been proven therapy for some. They find that they get relief from it. Emerging therapies in headache medicine. There are devices called neuromodulators and neurostimulators. They are non-invasive. Stimulators used to be surgically placed. They are non-invasive now for the most part. In some clinical trials, they reduced pain attacks in people just as much as medication did. It's good, safe for pregnant people that have headaches. It's good for people that have the contraindications for the medications. And it reduces the chance of any drug-drug interaction. So a lot of your patients that are if you may be a little bit older and have a list this long of medicine, it reduces your chance of having any interactions with that. And it's good to try for somebody that nothing else has been effective. Just, why don't you try this? That's the GammaCore and the Stethely device. GammaCore just got its approval for chronic migraine. It used to just be approved for cluster headaches. CGRP. This is where headache is going. Any headache. In any headache disorder, they found that the CGRP levels are elevated. It's definitely present at all migraine pathogenesis sites. Some man somewhere got somebody to agree to get an infusion of CGRP to see if it made their headaches worse. And it did. It triggers a headache in people that suffer from headaches, but not in the people that don't. There's no preventive treatment right now that specifically targets CGRP, but there is one coming out soon. Most recently, 4 different companies they've been battling it out, can prevent headache, studying the drugs that can prevent the headache by blocking the effects of the CGRP. The other 2 companies have been studying drugs with anti-CGRP effects, and these are attack medicines. These help the headache in the moment. So one is going to be for prevention, and the other one is going to be for attack. It's supposed to be released in May of 2018, and when they say that, it'll probably be by August. The others are expected to be released in 2018 or 2019, and they'll be available at headache centers across the United States. I'm sure they'll have some nice little perks and copay cards when it first comes out, so people can try that medicine. We're very, very excited about it. And for some people, I've tried everything and nothing works. They'll come to me and they'll say that. A lot of post-traumatic, post-viral, new daily persistent headache patients come to me and say, I've tried every medicine for migraine that there is, and my doctor diagnosed me with migraine, and I've tried everything, and they'll give me a list, and it rolls out like a scroll. in those people, especially if you are a post-viral headache, most of the time when you are being diagnosed, and probably all of the time, I don't really know, but you are going to get a spinal tap, if not several lumbar punctures when you're diagnosed with this. Patients that have exhausted all of the traditional headache treatment options should see a specialist to rule out something that's called low pressure headache. It's when you develop a small, tiny leak at the site of where you were punctured, and this can cause the pressure in your head to lower. It can cause a debilitating headache, daily headache, that only is resolved. Sometimes it's resolved by laying down, but after a while those posture changes don't affect it, so it becomes misdiagnosed often. So if nothing has worked for you, then that's something that needs to be considered. And we actually diagnose probably about one of those every week. It's just highly underdiagnosed. So headaches associated with West Nile can be the indicator of the virus, a short-term issue that's associated with the virus, or it can develop into a long-term chronic headache disorder. The neuroinvasive West Nile virus is characterized by the severe headache. However, it usually resolves, and if it doesn't, it will become chronic. The patho of chronic post-viral headache mimics that of migraine, and therefore it should be treated in the same fashion. And the emerging therapies, the CGRP, it really does offer a new hope to a lot of people that suffer from headaches. And that's our headache center. And you can look at the list of the headache disorders, and we also just opened up an infusion center in our practice where patients can come or be referred and receive IV infusions of things like Depakote, magnesium, IV meds, Toradol, Compazine, Benadryl, Reglan, just any sort of acute medicines. Okay, that's it.
Thank you.
At this time, if anybody on the conference call has any questions, please enter them into the chat room. Or if anybody in the room has any questions for Rebecca, we'll go ahead and take those now. And if nobody has any questions, we'll wrap up the call. Thank you. Some questions for you, Mr. Rebecca.
I have a couple of questions because I'm here to learn from you. I had meningoencephalitis, and I had what a neurologist called shooters. And I've not heard another migraine patient complain of this, but this was like 10-second, random, ice pick like pain only on my left temple. They were random. I could correlate it with no stimulus. Where does this fall other than your virus association and your spectrum of migraine? They wanted to give me a migraine medication for it, but I declined that because it's such a short interval of time. But it lasted over a year, and now they've disappeared.
What you're describing sounds like idiopathic stabbing headache, which is a short-lived, very short-lived stabbing headache on one side of your head, lasts for less than 2 minutes. It's usually treated with a drug called indomethacin. Migraine medications will not work for that headache. Of course, you can't chase your pain when you have these headaches. You can't just take something immediately because it doesn't last long enough to do that. But if it becomes too annoying or it bothers you too much, you can do that NSAID 3 times a day, and you can prevent that headache from happening. It's usually self-limiting. It usually resolves on its own. So it's not necessarily a migraine process, but it is a headache disorder.
I have one other question. I've been looking at the causes of long-term effects of West Nile virus. There are several things that go on neurologically that can form a positive feedback loop, which feeds on itself and perpetuates the. And one of those is nitric oxide, and I know that's involved with headache. Could you speak to that? Because there are ways to stop that.
Can you repeat
positive
his
feedback.
question so they can hear on the
question again. I was following you.
Okay. Speak louder, you're saying. I've been looking at the long-term outcomes of West Nile virus, particularly with encephalitis.
Mm-hmm.
And there are several positive feedback loops that can form with various chemokines and such that can perpetuate the long-term effect. One of those being nitric oxide. And I know that's involved in a headache pathology. What could you tell us about that?
Nitric oxide, typically, it's not that involved in the migraine pathophysiology, if that's what you're asking.
Not at all?
It is, but not as involved as other, neuropeptides like substance P and CGRP. So.
When you started off, you mentioned 3 types of meningitis and encephalitis and
Inferior myelitis?
anterior myelitis. And the third one did not have a headache association. Prevalent is up first to, can you explain that?
I honestly think that would be a better question for someone that knows more about the West Nile virus in itself.
I can go ahead and answer that. Okay. I will. So the question was the anterior myelitis, which is probably better known as poliomyelitis. It's what happens when the West Nile virus enters the gray matter of the spinal cord and then infects the spinal motor neurons. And so to actually have that occur, you actually do have to have a meningitis because it's the cerebral spinal fluid actually circulates around the spinal cord and goes through the brain and actually circulates about 7 times in a matter of hours. And so you have to have a meningitis, but you're right. We have seen a lot of cases where only the poliomyelitis variant is manifested, and it doesn't sometimes occur with fever or any type of meningitis, even no headache, and none of the classic symptoms that the classic viral prodrome. And so it's not unexpected for there to be a poliomyelitis like spinal cord problem without headache. I can't tell you why. I think this was also true in the old polio epidemics of the 1940s and 50s. Those children who became infected didn't have to have, headache per se. And to my recollection, a prolonged, recurrent, or chronic headache was not one of the typical manifestations. Good question.
Mm-hmm.
If you had the West Nile virus or a spinal tap, how long might it take for these headaches to develop if you don't currently have them?
That is a wonderful question. It can take years sometimes after a lumbar puncture or a spinal tap for someone to develop the headache that is related to that. It's a very scary headache to have. And it does not respond to any treatment that we can offer other than just going in and doing multiple blood patches. A CT myelogram can sometimes diagnose these headaches, but if you do have a low pressure headache, the CT myelogram is going to make you worse before you can get better, and there's no guarantee that the first or the second or the third blood patch will be effective because it has been so long.
Are you saying that you have a continuous leak for years?
You can.
That causes the headache?
You can.
And if it heals after the spinal tap, you probably won't have it anymore?
If it is that type of headache.
Let me give an example, okay? So kind of clarify it. So the issue is post-lumbar puncture, but headaches that can be chronic. But another scenario where we see this type of condition is a minor trauma, particularly facial trauma. And what we sometimes do miss is that there's a leak that has occurred, and there can be draining from the nose, and that can go on for amazingly long period of time. In the old days, what we used to do was we had little steri strips, and we checked for glucose, which is present in spinal fluid, but not in the other fluids that typically drain from the nose. One of the big questions was why these patients who have an opening between the spinal fluid and the external world weren't having, they weren't suffering from meningitis. Sometimes they would go for months or even years with only the fluid leak and that low pressure state and that chronic headache until it was clear that they had actually suffered a brain or a spinal fluid leak type of pathogenesis. So it actually can happen.
That would be a leak unrelated to the spine.
No, but it's the same issue. So if you do like a CT, like a myelogram or a spinal tap, and you have a fluid leak, the majority of those cases are going to, especially within a week, you should be free of headache. But the issue is that no one's going to be surprised if that doesn't happen. I mean, one of the papers I wrote was on a family member who actually had that type of problem. They went in to fix a herniated disc in the low back, and they clipped some of the lining around that spinal canal. And I mean, for a long time, that was very difficult to try to patch it with just a blood patch. And so there were other, mechanical mechanisms. That person ended up doing well with just a weightlifting belt and a direct physical pressure applied to the area of the leak. But it was also fairly apparent because the area of the leak was actually causing a big hematoma-like collection of fluid. And eventually it did heal, but it can go on for a long period of time.
I've had a patient that's had a spinal CSF leak for 25 years, and she had a chronic daily headache, and she went to get one blood patch, and it resolved. She no longer has headache.
You should write that one up.
I know. Anyone else?
No other questions? I've got one that we have interest to know of the thing. I'm an electrical engineer. But you mentioned this new gamma core stimulator.
Yeah, it's out.
Do you know anything about how that works? Transcutaneous direct current?
Yes, and it stimulates the vagal nerve in the neck.
Vagal nerve stimulator. Direct current?
I believe so. It feels like a direct current. I don't know the science behind it.
The pictures you put up showed it wrapping around like.
That's the Cephally device.
I'm sorry?
That's the Cephally device. The gamma core is the neck vagal nerve stimulator. That's the only one we use at our clinic. I'm not a huge fan of the Cephally device because I haven't read enough studies where it's been effective. But some people like it.
And usually when they stimulate the neck, that's more invasive. That's an implantable device.
Right. They used to be invasive. They used to place the stimulator under the skin, and now they've developed this way with the gamma core device. I can give you some information on it, that they can do it externally and still stimulate it. The patient's able to take the actual device and turn it up or turn it down based on when they feel the pull of their lip, signifying that they are indeed, stimulating the vagal nerve. They can go up or down to their preference.
I thought the only location where the vagal nerve could be stimulated was inside the outer ear. And you're saying it's on the neck?
It is on the neck. Mm-hmm.
So the question is it helping other parts of the body with the vagal nerve stimulation?
I haven't had a patient tell me that, and I've not read any research on it. That's a good question. I would wonder about that.
Because they were using it, I know this, for that same device.
Well, the gut and the brain are closely related.
Yeah. So the vagal nerve stimulation actually became popular about 1990. And I remember some of my initial work was on epilepsy. And that's when vagal nerve stimulation became, one of the fads in the early 1990s. And I sort of got away from it. But in a simple way, if you take a nerve that has all these minor tributaries that are going to the brain and to every other internal organ of the body, because the vagus nerve carries all the what we call parasympathetic information. So vagal nerve fibers will supply the entire gut, which was actually it's a brilliant question, because what a lot of patients who do have West Nile virus infection also have a dysautonomia, meaning that the autonomic nervous system takes a real hit. And we think it can be directly from viral infection, and we think it can be also a post-infectious, presumably auto-inflammatory or autoimmune state. And both can happen. And so I kind of like where you were going with this, which is, can she apply it to, let's say you had gastroparesis, would you be able to apply it here and activate vagal afferents, which would then should have an effect on increasing parasympathetic drive to the GI tract.
Why don't you come to the clinic and try it?
Yeah, I would endorse
We
that.
we have one at our clinic. Yeah.
Yeah, I would endorse that. Okay, that would be nice to try to figure that out.
Dr. Lake, you give me an opportunity to kind of voice my opinion. I think it's been good to do it together. But today I look at life going down to the research department, and you get down to healthcare department to develop and develop the way the last administration has been operating the people of Washington, the way they're cutting back on all programs. I remember I used to work for a pharmaceutical company. We got all good, and they don't want you to use animal as research. Now we only use animal as research. The electronic ideas is coming out. And don't give them the answer, I don't think I feel very strongly that the development of the computer and the cellular phone is the most dangerous thing that ever been put out. It's only good for people that can afford it.
Yeah,
we're worse off now than we ever been before. I don't think we can stand slavery. That this system in the United States is doing things. The reason I say that is because in reading the other day, the Mississippi legislature you get $200-some for Medicaid. And if the parents do not work 20 hours a week, the child cannot Medicaid.
But I'm going to have to just make a comment here. These are important social commentaries. And I'll tell you, I know that healthcare in America needs some fixing. I know that there are clearly problems. From our perspective, from the patient's perspective, from the insurance company's perspective, and certainly from pharmaceutical companies that produce drugs. And we all have legitimate concerns. It's not going to be a very quick fix. Yes, we can also make a social commentary, but what we need is to literally come up with solutions. And I got to tell you, I don't think those solutions are going to be so easy to implement. Okay? And we can talk about that later, though. Any other questions regarding West Nile, headaches? Does anyone have any new headaches that you have the ability now of having a headache expert here, of just mentioning the headache, and maybe we can discuss, some features of it. Yeah, please.
I've been having headaches that start here, well, since right after they start right on the side,
So these are headaches that start on the side and then go up to the top of the scalp. Okay, and the question is, this is not your typical frontal headache, and what are they?
Migraine and post-viral headache, as we were talking about earlier, are very closely related. And just because the diagnostic criteria of those headaches says that it has to be on one side, that's just not true. You can have involvement of any nerve pathway in the head. It can transmit pain from anywhere. You can feel the headache here and here if that's where you have that process happening in your brain. So I'm not shocked to hear you say that, but I would like to know how long the headache has been present, how many years?
5 years out, but it's not constant.
You have pain-free days?
Oh, yeah, yes, I do. But I've had more recently, and will stress for us cause it?
Certainly. Stress will cause anyone to have a headache if they're a migraineur or if they suffer from any sort of headache. You come see me.
I would endorse that too. Any other questions?
I will tell you my headache history.
Okay.
I'd love to hear it.
I got West Nile encephalitis. When I got West Nile, I just wanted a hole in my head. That's all I wanted. Didn't want just relieve the pressure out of my head. The second hospital trip, they did a spinal tap. I had a spinal tap leak. They did not want to patch it. It had to heal on its own. I had CAT scans to make sure that it's been healed. Supposedly it has.
Let me interject you. CT scans or CT myelograms?
CT scans.
Yes.
Okay.
I currently take Max 100 milligrams twice a day as per minute. And I am happy with that. Basically the max. I do have enough. I would be happy to go up. I take Amitrex injections as emergency headache relief. Most of my headaches are right here, over my eye, and have basically kind of always been. I am very light sensitive, but my pupils don't really dilate all the way. So I have headache-free days more now than I did. At Mayo Clinic, I did have a nerve block, which was amazing. That was probably the most relief I had. So that's kind of where I stand. I kind of live more with headaches and kind of deal with them. I have gastroparesis and have very horrific gastritis. So I'm trying not to take anything that will irritate my stomach.
That's a good story. So, where in Louisiana do you live? We would love to see you at the Headache Center. You can go up on your Max if you need to. Who's your neurologist?
Yeah, I don't.
Okay. Is your primary care doctor treating your headaches? I really think that, given your history, that you would probably be a good candidate for Botox injections.
I've tried Botox.
How many rounds?
The first round I did the max, and my neck is paralyzed.
That was an injector error.
By the neurologist. I couldn't hold my head up for about 4 weeks. I'm passed out.
That's okay. All my patients pass out when they get it. It's not a big deal.
I didn't pass out.
We just fan them.
No, I didn't pass out in the office. I passed out a couple of days after. They weren't always related or Botox related. The second round I did okay, but it didn't get rid of the headache. So I opted not to go for a third round.
The current literature says that it reaches its maximum level of efficacy at the third round. And I do have patients that will get both rounds and not even see 1 day of relief or changes in the duration, the frequency, the severity, none of the above. And they will do the third round of Botox consistently. You know, you have to do it every 12 weeks. But when they do the third round of Botox, it is effective. Well, we have patients from Arkansas, Texas, Louisiana, Florida, Tennessee, and one from North Carolina. So.
Any other questions? Yes.
This may be as much for Dr. Lace as, or maybe both of you, but I know it's appreciated in some subspecialty arenas that there are variants of migraine that are not pain-related, such as chronic vomiting syndrome.
Okay, so we're talking about variants of migraines like, what was that?
Well, I understand now it's appreciated chronic vomiting syndrome.
Sacral vomiting syndrome, okay.
Do you see this on post-viral?
So that would clearly be a question for my colleague.
I would think that would be, I'm not sure if there's ever been any research on whether the children that present with the cyclical vomiting syndrome or without headache, the adults that come with or without headache, you rarely see an adult with, abdominal migraine or cyclic vomiting syndrome. But I would think that what was your question?
Well, do you see that?
Like I don't take care of a lot of post-viral syndromes that aren't headache. Does that make sense? We're specifically a headache specialty, so most of the time we don't see those patients, so I wouldn't have enough data. And I'm not aware of any data that's been published in that area. The data surrounding post-viral headache is very, very low.
So let's get a show of hands. I mean, what about the headaches that each of you has encountered? I would assume that most people, at least in acute illness, are going to have headaches. Were they associated with vomiting? Were the two together, or were they? Okay, so I see at least two people shaking their heads. Yes, vomiting with the headaches. And afterwards, did that persist with headache and vomiting, or just it kind of went away on its own? Okay, kind of went away.
Still have headache,
No, not with vomiting.
And that's typical of chronic headache. Mm-hmm.
And so yeah, I tell you, I have not come across headache is not my passion, obviously, but I have not come across individuals who have that type of combination, because I would have remembered, gee, this patient, 5 years later is still having, headaches associated with vomiting. I don't think I've come across it, except during the acute illness where you can have nausea, vomiting, diarrhea, and a constellation of other symptoms, most of which will disappear. Go ahead, please.
These headaches, could it be part of heredity?
So the question is, could heredity contribute to headache?
Yes, it can. It can increase the likelihood that after an infectious process that you will get that post-viral headache. Most headaches in general are hereditary. Chronic migraine, migraine with aura, hemiplegic migraine, all of those have been shown to have a genetic component. So genetics does play a role in whether or not you will develop a headache after you have West Nile.
Have you noticed any difference treatment?
Mm-hmm.
Someone who's diagnosed with West Nile virus and get better results, but then you got a comparative set of data with people who got treatment the first week versus the first month versus the first year?
Yes, there is a study out there that does compare those two things, and I can give you that information.
But if someone were to be diagnosed in their local community, what might be a way we can communicate with our medical staff to say, call this girl and, your office or...
Where are you guys? Where's your medical?
Alabama.
What part?
Tuscaloosa.
The owner of my clinic comes and she goes to different locations and gives them education and pretty much, business cards and pamphlets and says, hey, this is who we are, this is what we do. Send your headache people to us, because a lot of people don't like to deal with headache they don't recognize headache as true disability, and it can be disabling. So she does a lot of marketing. So if you want to give me the information of where your family practice is that you want us to come to, we can certainly come and bring them lunch and teach them about headache.
Well, I'm fortunate I don't have headaches, but I just wonder because when I was diagnosed in July with West Nile virus, I had a staff of doctors and they knew nothing. You know, I was just.
I understand. That's yeah, the rural community.
Back to that social commentary.
I was diagnosed with West Nile in 2002 and on and off had the headache ever since. Last year I got a vestibular migraine, just totally out of the blue. Is that normal?
That can happen with anyone. It can affect a different area. I mean, we have some patients that will have never had an aura until maybe they're 60, and then suddenly they develop a headache with aura. It's just all about how the process is affecting your brain. But those are tough.
So
Hopefully you don't have one again.
Well, what is it? I'm sorry, vestibular migraine? What is a?
It's a migraine that's associated with vertigo and severe spinning.
So we're talking about vestibular migraines. I mean, people are listening, so we have to. Okay. Any other questions?
Where's the treatment for that?
The treatment for vestibular migraine is actually quite interesting. You can treat these headaches with Xanax, PRN Xanax. And of course, you typically, when you see someone that is having a vestibular migraine or migrainous vertigo or vertiginous migraine, it goes by a lot of different terms. But when you see a person that's having that, they're usually being treated for migraine anyway with the traditional therapies like the triptan medications and NSAIDs. But the treatment that's specific that we found that is the most effective, and we are a non-narcotic, non-controlled clinic. We don't prescribe any controlled substances in our clinic for headache except for Xanax for the vestibular migraine patients and Valium prior to an MRI. No, you can't see the migrainous process on MRI. There are some changes in the white matter that are present in chronic migraineurs. I also have a study on that I can let you read, but just seeing if someone has migraine by looking at their MRI, you cannot do that. Now, in regards to the low pressure headache that we were discussing, there is a really good video of a physician from Stanford that was talking about how often a low pressure headache was missed on an MRI, and we are trained at the Headache Center to see those subtle changes.
Okay. I think that's probably it for the questions from the audience here. Are we taking any of the questions now from elsewhere? Okay. And so we'll go ahead and conclude. And Becca Adams, thank you very much. That was a beautiful presentation.
Wonderful. Thank you guys for having me.